we know there's actually a number of reasons that someone might feel anxious in regards to flying.
How is social anxiety different from just being shy or introverted?
Where it starts to look more like social anxiety is really in that anxiety piece, right?
when they're in the virtual reality, what does that look like?
Again, this is one of the strengths of virtual reality, is that we really can graduate, break up into their individual components.
Hi guys, my name is Adam Hutchinson. I'm the founder and CEO of oVRcome. Thank you very much for tuning in to our first ever webinar done by oVRcome. We're very lucky to have Dr Corrie Ackland with us for this Q&A, and we'll touch on a few strategies, learn a little bit about phobias, learn a little bit about anxiety, and hear from her first-hand experience with using virtual reality in her clinic, the Sydney Phobia Clinic. Now, today's webinar is going to be pretty conversational. There'll be the ability to ask questions, and we'll also prompt Corrie for a few bits and pieces of information as well throughout this. I also have my colleague Kasha with me, and Kasha will also be helping facilitate this. So thanks everyone for joining, and over to you, Kasha.
Thank you, Adam, and hello, everybody. Thank you and welcome, and of course, thank you for joining. My name is Kasia, and I'm a Client Success Manager at oVRcome. I oversee our support and work closely with our users to ensure that they have the best experience possible. And it's always great to connect with both current and potential users. And really, the goal for today is to reassure you that there is a passionate and dedicated team behind oVRcome, and we are ready to support you. So if you have any questions about anxiety, phobias, virtual reality throughout the webinar, just feel free to post them in a chat, and we will make sure to pass them on to Corrie, who is our clinical psychologist today, who is here to help us all get the most of our time together in this session. So really looking forward to today, and once again, thanks for joining.
Corrie is a clinical psychologist, and she is the owner of the Sydney Phobia Clinic. Has been doing virtual reality exposure therapy for over 9 years. So welcome, Corrie, and thanks for giving us the time for this Q&A.
Thank you, Adam and Kasha, and hello and welcome to everyone online. And thanks for that introduction. So yes, my name is Corrie Ackland, and as Adam said, I am the founder and director of Sydney Phobia Clinic. We are a dedicated private practice for the treatment of specific phobias. And we've been doing this now for, as Adam says, coming up to 10 years, which is a huge feat to be servicing the phobia community. And we are really honoured to be doing that. And a bit of background about the clinic. So I founded Sydney Phobia Clinic in 2016 with the mission myself of being able to support as much best practice exposure therapy in a therapeutic setting, which we know in a private practice setting can be hard to achieve. There's a number of limitations to providing exposure therapy, but we also know that this is arguably the most effective part of a cognitive behavioural therapy treatment for anxiety disorders broadly, but especially for specific phobias. So being able to open a dedicated practice allowed us to really make sure that we were doing that by resourcing the clinic for exposure, partnering up with nearby companies that could also assist us in real world in vivo exposure, but especially being able to incorporate virtual reality to our tools of exposure. And I think that has really enabled us to help so many people in a very brief amount of time, which I'm sure we'll speak to over the course of today, how we go about treating phobias at Sydney Phobia Clinic. But virtual reality has, we believe, been the real kind of magic that we're able to bring to treatment. So I look forward to going through a lot of that with you. And yes, thanks again, Adam and Kasha, for having me.
No, thank you, Corrie, and yeah, really excited to hear about some of those almost case studies or clients that have come through, and I'm sure we'll talk about those very soon. Perhaps if we kick off with a bit of a background or an understanding about how specific phobias come about for the majority of people. Tell us a little bit about that. How do phobias appear and affect people the way they do?
Yes, certainly. So, at the core of specific phobias is our normal adaptive fear response, which becomes unreasonably attached to non-threatening stimuli, or in excess of any threat or danger actually posed. And there can be a number of reasons for that unreasonable attachment of the fear response to these non-dangerous stimuli. And one of them is early negative learning experiences. So a lot of people do really try hard to figure out, what was the big bad thing that happened during childhood. And we do know that childhood is a very sensitive learning period where a lot of our learning experiences can be quite potent in our sort of later development. And so early learning experiences that are negative can be the onset cause for specific phobias to then develop. And it can be that the individual has had themselves direct learning experiences, or this learning experience could be what we call vicarious or observed. So it could be observing a family member demonstrate fear in association with the phobic stimulus. It could be hearing something. It could be viewing something, even on television, that lays down this idea that this stimulus is dangerous and therefore will elicit the threat response.
So are you sort of saying, Corrie, that if I've seen my mother, for example, reacting to spiders, then there is a chance of me sort of picking that up and carrying that through, and that sort of forming the phobia?
Yeah, that's right. So these learning experiences are particularly potent during childhood. But the other thing to note is that these learning experiences can happen across the lifespan as well. So we are still always learning and we are still vicariously learning. And we do still have these kinds of experiences over our lifespan, some of which can be negative or threat-based. And so these threat learning experiences can start off this phobic response. And we really, in that way, think of it as a bit of a learning funk, that these situations have kind of been wrapped up with an association with the fear response again, unreasonably.
Yeah.
But that's kind of the onset picture. And we do know that the maintenance, what keeps the phobia going over time, can actually be a little bit different.
Okay, that's interesting. And I mean, Kasha, both you and myself have had feedback coming through from people just to sort of see the extent of the challenges that people have and the way that phobias will affect them in their day-to-day life. And so, it's a really worthwhile challenge for us as a team to be making this treatment more accessible. So really good to understand around how those phobias sort of come about. But we also, do know firsthand about the consequence that they will have. So if someone has recognized that they do have a phobia, perhaps they've perhaps been diagnosed, or maybe they've run a test, or maybe they just realize that they've got some significant avoidance challenges. What are some sort of go-to strategies that someone might use when they're in either an upcoming situation, perhaps they've got a fear of flying and they need to take a flight, or perhaps when they're actually in those particular environments, maybe they're on a flight already and there's turbulence, for example. What are some sort of pre and maybe during the situation, like what are some strategies that they might like to use, do you think?
Sure. So the evidence-based treatment for phobias is a cognitive behavioral therapy. And to understand the components of that, I think leads into those strategies. So a cognitive behavioral therapy looks at the interrelationships between what we're thinking, how we're feeling, and then what we're doing. And this can become quite cyclical, and that is certainly the case with phobias, where we know there's an interpretation of threat. It kicks off our threat response, which is all of those anxiety symptoms. And then we tend to react in a way in line with those symptoms. We tend to want to escape or subsequently avoid, or otherwise rely on certain coping strategies, which may or may not be adaptive coping strategies. So then when we're looking at what kinds of things might be helpful, we kind of break it down into those sort of three buckets as well. What are some strategies we can use for how we're feeling, that anxiety? What are some strategies we can use for what we're thinking? And then what are some strategies we can use for the behaviors? So when we're looking at what we can do to manage those physical feelings of anxiety, we look at things like controlled breathing, recognizing that our breathing does certainly change as a primary symptom of that threat response. And so being able to calm that breathing down can change those feelings in the body. But the best part about the breathing is also probably that it means that we are going to be more able to think. Because if anyone out there has experienced that anxiety, and I'm sure that they have, we know that all rational thought tends to go out the window when those feelings are heightened. So bringing that breathing down also allows us to do the next strategy, which is a thinking strategy. Other physical management strategies that we might use is a progressive muscle relaxation to again combat the physical tension that we might hold in our body when we're anxious, and also to help represent the situation as one that we can relax in and that we don't need to be tense and on guard for. Mindfulness or grounding techniques are other ones that sometimes we can use to again help the physical feelings that we might be experiencing. And again, these are strategies to kind of help the next part of the picture along. Looking at the thoughts then, we would say that it is important to be able to, as accurately as possible, identify in what way we're interpreting a threat. We don't want to assume, Adam, you gave the example of someone with a fear of flying or anxiety around flying. We know there's actually a number of reasons that someone might feel anxious in regards to flying. We don't want to presume it's safety. It might be the fear of heights or claustrophobia or fear of germs or fear of vomit, or these days even dog phobia plays up on a plane because of all of the therapy dogs. So we do want to be able to be targeted with thinking strategies. The first step is identifying what it is that we're interpreting as threatening. And then we want to combat that with reasonable facts, evidence, other perspectives to neutralize that threat appraisal, but also to be increasing our perceived ability to cope with that situation. So relying on evidence of where we've coped before or why the situation is one we could cope with.
Okay, that's awesome. Those are some really good tips. And so, we talk with a lot of people that don't necessarily know much about what their specific phobia is. All they know that they're on a flight and they're feeling very anxious. Like, what would your advice be to someone, if you want to get to that root cause? Like, is it sort of just to think a little bit more about, or do you sort of ask them about what was that environment that they were in and describe those sorts of things so that you can sort of narrow in on what is causing that specific, the anxiety?
Yeah, and you make a really good point, because I've also had clients in that situation that didn't have a fear of flying until one day they went into the situation in good faith. And then boom, this, massive anxiety feeling, or in some cases panic attacks were elicited. And then that kind of started the fear of flying from there. So look, we don't always know what the initial anxiety can be about, especially if we've otherwise been stressed or our lifestyle factors have been a bit off. Sometimes we might get on a plane after a really crummy night's sleep, haven't had a chance to eat, might already be dehydrated. There could actually be other reasons for that anxiety coming up.
Mm.
But once it's developed, we do know that for it to maintain, we're engaging with it in some way.
Yeah.
And in that regard, that's when it's important to be understanding, well, what is that fear? What are we worried about? And a simple inquiry at that time can usually lead the brain to offer it up to us on a silver platter, so to speak, where it goes, the wings are going to fall off, or something like that. And then we've got it, and then we can work with it.
Gotcha. Yeah, no, that's a really good point. So with the Sydney Phobia Clinic, obviously, known around the world, like give us some sort of, some case studies or, what are some examples that you've seen of people that have come in and, recognized that they've got a specific phobia or a challenge and they've gone through, the virtual reality exposure therapy and had a really good outcome. Like what does that sort of journey look like?
Yeah. So there's a couple of real classics that kind of come to mind. In fact, I had a client reach out recently who had completed our arachnophobia program, a 5-session program, and she did really well. And actually, she reached out to share a photo of the very first huntsman that she caught herself independently at home. So, a really great sort of outcome for her. The way that we do it at Sydney Phobia Clinic is with a manualised 5-session treatment program. The first step of that is a lot of psychoeducation, really, getting on the same page with a client around a lot of the points we've actually already covered. Why does this develop? What maintains it? What do we need to do about it? And then looking at some of those physical management strategies, which we would then practice over an intervening period of maybe a week or two, looking at those thought strategies. So for the client I just mentioned, it was very much about her perceived inability to cope with the spider that was so quick and unpredictable. But there was also a really quite strong disgust element to that, which we had to work through. And then we begin the exposure therapy design, designing a structured hierarchy where we're ranking the kind of more easy situations that she was avoiding to some of the more difficult ones. And we progressed through that. So starting with cartoons, going through towards photos, going into videos, using toy spiders that are different levels of realistic. And then the virtual reality exposure allowed us to view real spiders from a distance, and then increasing towards first person point of view virtual reality, where we were catching and releasing a spider in virtual reality. We then did some in vivo exposure, so bringing a huntsman in a container into the clinic so that she could practice using those strategies in that real life environment and see the virtual reality generalize into the real environment. And then, as I said, then some months later, getting a photo from her with this awesome result of being able to do that independently.
It's great. And I guess that's the ultimate goal, isn't it? Transitioning someone into in vivo or real life exposure. Like the virtual reality is sort of a step to that. It's like a middle step, so to speak. But the ultimate goal is, is the in vivo exposure to ultimately overcome it. Have you noticed do any trends exist with people that have phobias, or do they not discriminate? They affect everyone and everywhere. Are there any trends, or have you noticed anything recently, perhaps around people that have a specific phobia?
Yeah, so it's a good point. We know that specific phobias are some of the most common anxiety disorders. And they are very, very prevalent where people have other anxiety disorders. So we say that they're quite comorbid. And in these cases, they actually may not be the focus of treatment. These other anxiety disorders or mood disorders, other difficulties may be the priority in treatment, and the phobia just kind of gets left to the side, left behind. But we also know that phobias are an example of are quite a clear and straightforward presentation where someone may struggle very severely with a specific phobia, but otherwise not have any other mental health challenges. And so, yeah, in these cases, it can sort of be either. And then in terms of what kind of phobia they may struggle with, this can, again, it can affect anyone, and it very much depends on the negative learning experiences that they may encounter. But also what we call latent inhibition, which is any prior positive or neutral learning experiences with the stimulus before a negative event happens. So we know that this is also a really important component that might buffer phobia development.
Okay, no, that's really interesting. So I've got some questions here that I'd like to sort of run through, but for any attendees, if you want to post some questions to Corrie, you can do so using the Q&A feature, and then they will come through, and then we'll do the best we can to get those answered for you. But I'll just start off with a couple that I have here. So the first question is, can a phobia get worse over time, or does it stay the same? Like, what's that sort of, what's the typical evolution, so to speak, of a phobia?
So a phobia left on its own will tend to worsen over time to the extent that the stimulus is avoided, or else continues to be managed in a maladaptive way. However, where the individual has continued to participate in these environments and alongside this stimulus, it may very well improve, even without formal treatment. So, that I guess is in line with our intuitive expectations, right? That the more we do something, the better it should get. And so that is always our overarching message is, if there is something that is, unnecessarily scary, any little steps in the direction of that thing can help. And it's only really if that is too tricky to do that we would really say, well, now it's the time to rush in with treatment.
Gotcha. Okay, I've just had another question come through. So, what's your view on, is medication a good solution for a fear of flying, or do they actually hinder long-term progress? What's your view on that?
So, yeah, we do know that medications are quite frequently prescribed for fears of flying. And look, they don't always get in the way, right? I think it very much depends on how they're being used and when they're being used. So in the case of medications that might be being taken daily for a general anxiety, these may not get in the way. But if medication is taken at the point of the phobic trigger, so for example, we're sitting on a plane, turbulence hits, anxiety spikes, and we reach for a medication to reduce that anxiety to help us cope, this is likely to be what we call a safety behavior and may very well get in the way of us learning that we're safe in that environment because the brain attributes safety to the medication instead of the environment.
Yeah, that's interesting. I remember we had some feedback come through from an oVRcome user that they were a lawyer and they had to travel a lot for their job. They had a severe fear of flying, and then they would take anti-anxiety medication. But their problem was that, they'd get on the flight, but for the day afterwards, they were completely gluggy, and it was sort of a real sort of, they were really struggling with other options. So, we understand that it can have that sort of consequence too of just feeling very drowsy afterwards too. I've got another question here. This one's around social anxiety. How is social anxiety different from just being shy or introverted? Like, what's that sort of threshold in your view that tips someone into having social anxiety as opposed to just being shy?
Yeah, and so I think, if we're introverted, if we're shy, we can still be quite comfortable in social environments. However, it might be that feel like we are happier listening or being quieter, or might be just as comfortable in our own company. Where it starts to look more like social anxiety is really in that anxiety piece, right? When we're going into social situations and it is being associated with an abnormal, sometimes interfering level of anxiety, or if we're actually avoiding these situations entirely due to the fear of them or the fear of the anxiety that we expect to be elicited. Yeah, that would be my answer for that one.
Yep, that's all right. Got another one here around needles this time. So, what role does avoidance play in maintaining a fear of needles? And how can someone sort of work towards those feared situations? Because I guess what they're asking here is probably like, day to day, we're probably not confronted too much with needles and we can go on avoiding. But when it does get to that vaccination or time that we have to have an injection, that's probably the real crunch time. So, do you have any tips for someone that does have a fear of needles that might be able to do that sort of, desensitization or, what's your,
Yeah, so again, avoidance is probably our most potent maintaining factor for phobias. So avoidance is going to maintain a needle phobia quite significantly. But I guess the other part to that question is, what if it's not intentional explicit avoidance? What if it's just the mere passage of time? I don't need many needles, but every time I get them, it's a really distressing experience. And I guess that calls to the importance of proactive exposure practice in the intervening period. So not waiting till you absolutely need a needle to getting either needle related procedures, things like vitamin shots can be quite safe. Acupunctures are nice way to get that practice in. But then there's also often a generalizing of that phobia to other stimulus such as photos, videos, conversations with other people. It might be to get the practice in that you become the wing person for any of your friends, injections or blood tests. There's obviously blood donations. There are creative opportunities to get that exposure in if you recognize that you're someone who's especially vulnerable to this anxiety festering if left too long.
Yeah, no, that's good. I remember the time of doing our clinical trial with the University of Otago, where we interviewed a lot of people that had a fear of needles, and some were so severe that even if they saw a needle in a TV show on TV, they had a reaction to it. So it's it definitely affects people in big ways. So that's a good answer. So what are the potential long-term effects of sort of untreated fear of flying on someone's sort of, like personal life? Like, what's your sort of view on that? Like, what can happen if someone just continues to avoid and doesn't deal with it?
Yeah, and fear of flying is, I will say, my favorite phobia to treat. And I think that, even going back 2 decades, if you had a fear of flying, the consequences on you might be pretty limited, because, flying was far less commonplace than it is now. But now it is the case that often workplaces are scattered around the globe, family certainly is scattered around the globe, and many people are traveling at just unprecedented rates, right? So if there is a fear of flying that's developed or developing, and certainly if it's associated with avoidance, this can really impact our work, our relationships. A number of my clients present for treatment because while they've been happy enough to avoid for a period of time, they've got a big family event, right? Their children may be getting married overseas or, have had babies overseas, and now they want to make sure that they can do that. So it's really not going to improve without exposure practice.
Yeah.
Just like with medical phobias, it suffers from a bit of an access issue when it comes to getting that exposure practice in. And I will say that's where the application of virtual reality is, such a game changer here, because it gives us that access, right?
Absolutely, yeah. We had someone that they hadn't flown in an aircraft since 1985, and their problem was that their mother was getting sick up in Wellington, which is around a sort of a 1.5 hour flight from where we are here in New Zealand. And they sort of went through the virtual reality exposure therapy, and finally they were able to fly. So we do know that there are significant consequences if people don't deal with the phobia. So that was a really good result. So, I guess just touching on a little bit more about the virtual reality. So, how do you do it with VR that it's done in a gradual way? So you've mentioned that you sort of start people off, fairly small, with photos and these sorts of things. But when they're in the virtual reality, what does that look like? Do you sort of gradually ramp up the sort of severity, or, just talk me through how you do that with your clinic.
Yeah. Again, this is one of the strengths of virtual reality, is that we really can graduate, break up into their individual components, these otherwise larger scenarios, so that we can get this entry point. And we can also prolong situations in real life aren't prolonged, like getting an injection or turbulence. And then we can repeat it over and over and over and over and over again as needed to really make sure that the learning that we're needing to make in that environment is happening. So that graduation still absolutely happens in VR, where we start off with an easier situation. Maybe that is the stimulus, but from a distance. In a fear of flying example, that might be the airport or the jet bridge, or it might be just a plain, smooth in cruise before we step up to the next level, which might be takeoff or turbulence or, the stimulus a bit closer. It very much depends on the individual, how we would arrange those things, but we do know that, virtual reality exposure therapy gives us that flexibility really nicely.
And it's a really good sort of lead into the next question, which is around so it's obviously very personalized to an individual. I mean, are you trying to sort of ask questions around, their specific triggers, and then once you know the answers and have established what their triggers are, you can then start to sort of construct what is that sort of those environments and how, gradual is it? Is that sort of generally how it works? Is it you sort of dive as deep as you can, as much as the client will know about themselves and their triggers, to then start to make those changes to the hierarchy?
Yeah, absolutely. So we would have a design session where we would be spending that time constructing the hierarchy. I will say that even though following an exposure hierarchy is quite traditional and often a preference for the client, it isn't the only way to do the exposure practice. And sometimes an individual comes in with a really specific goal and a bit of a time frame. And because of that, we might look at going to a bigger situation on the hierarchy, but finding ways of moderating it to make it easier in other kinds of ways. So I would hate people to go away from this today and think, oh, well, because I can't do an easier level, I can't do exposure at all. It's not the case. And we know that, the anxiety that we experience during exposure is safe for the body, even if it's not comfortable.
Okay, no, that's awesome. Another question is, what are some common physical symptoms of a phobia? What would someone's body typically go through? What would they see in terms of changes, physiological changes or otherwise, that would sort of indicate that, hey, I'm sure they probably know, but what are some of those sort of physiological changes that can happen?
Yeah, so our primary threat response symptoms are sort of a disturbance in breathing rate to bring in more oxygen to the body. We experience an increased heart rate and blood pressure, which pumps all of that stuff around the body. We may experience sweating. There can be some digestive changes, feeling nauseous, feeling butterflies, loss of appetite, urge to use the bathroom. There can be some agitation or restlessness. I would usually say they're our primary, and I would often encourage my clients to consider that they're really all of the changes that experience when we go for a run. And so actually they're our run symptoms. It's the body prompting us to run, to escape, in order to survive, because that's very much what it feels like is happening. So that's what's going on in the body. There's also some pretty neat perceptual and cognitive changes that result in a hyperfocus on the threat. Sometimes this is why it can be difficult to otherwise think. And so, yeah, there are primary symptoms. There can also be some secondary symptoms that kick off, particularly if we fail to manage the primary symptoms.
Sure.
And these are all the ones that probably wouldn't help you run away from a bear.
Yeah.
So breathless, shaking, some perceptual distortions, feeling muscle weakness, feeling a bit dissociated from the environment. Yeah.
It's interesting. I know I've personally sat next to people, on a flight, and I guess the closer that you get to takeoff, they're sort of moving around a little bit more, and they just sort of seem quite active. And then, they're sort of gripping the arm holds like really, really tight. So I've sort of seen it firsthand when people are starting to experience this. So that's really interesting. So another question here is, and you've sort of touched on it earlier, but is is fear of flying more about the lack of control, or is it tied to other anxieties like claustrophobia, which, yeah, you have touched on earlier, but what role does control play in a fear of flying?
Yeah, and particularly where there are safety concerns, control is a huge part. Many people describe, if I was able to fly the plane, I might be okay, or if they were able to sit in the cockpit, or, it used to be the case that we could see into the cockpit from our seat. That's a fairly recent change that we think does influence the anxiety experienced on board. Um, and it is why it is so important to get some education around the safety of aviation, so that we can have a little bit more of a sense of control. But then there is all of those other elements where, you're not flying the plane and you're not actually in control, that is reasonable to tolerate and to work towards accepting and tolerating.
Okay, that's awesome. I've only got a couple of questions left. If anyone wants to ask any more, now's the time to do so. But is there a length of time that someone should, should basically take in order to overcome a phobia? Like, is there any sort of general rule or guidance that you have about the length of time that it would take? Have any sort of feeling on that?
Yeah, it's a great question, especially where there's been avoidance for such a long period of time. Clients often do say, I've been avoiding this for 30 years. So, do I now need to do exposure for 30 years? And it's not the case, but there isn't a number, unfortunately. And particularly because as we go along the exposure journey, sometimes we identify that there are specific things that are getting in the way and halting the improvement or plateauing the improvement that then we need to troubleshoot. But hopefully what happens is after a period of really proactive exposure practice, we're then living our life in such a way that it provides some maintenance exposure practice
Yeah,
anyway, and that's what we
yeah.
would hope. So it's not an endured process.
Gotcha. Yeah, and I suppose part of the psychoeducation is about learning those skills that you can carry through, over a long period of time. So once you develop those skills, you practice them, then you've got them for life, right? So,
Yeah,
so
and you might fall off in your practice, and see things freshen up a little bit. And
yeah,
what we would want is for the response to that to be, "Oh, I need to go back to the practice." It's kind of like falling off your fitness in the off season. It's going to be a hard training first game back, but the more you keep up in the off season, the easier that's going to be. And if not, well then okay, it's going to be a bit of a challenge, but we know that those same steps can be followed to build that back up again.
yeah, cool. And just on that, do any sort of seasons exist for phobias in the sense of do you start to see more people over the winter time where maybe they're not going out as much and they want to dedicate some time, or after New Year's, for example, maybe they have a New Year's resolution. Is there a typical sort of season for people dealing with these?
Not phobias broadly that we've seen, but anecdotally, we do see that arachnophobia presentations die off during the winter because people are
Yeah.
pretty confident that they won't really see many spiders. And then they start coming in as the spider season kind of ramps back up again in the back half of the year. Similarly, public speaking anxiety, we often see around March, April, where people have had a bit of a break from speaking engagements over the Christmas break. And then when they come back, they're taken by surprise at the anxiety, manage it in a maladaptive way. Phobia kind of freshens up, and then they come to us around, yeah, March or April.
Yeah, that's really interesting. I know one individual that came to us, they, had avoided, exposure for such a long time, but the point that they realized they had to do something about it was they were driving in a vehicle with their family. There was a spider in the vehicle and they almost had an accident. And that was the point where they realized, wow, this arachnophobia has really got a hold of me. And that is the time when they started to deal with it. So it's been really interesting collecting feedback and understanding more from people around how this impacts their life. So that's it for the questions. If anyone has any others, hopefully we've answered them all accurately, and you're happy with those responses. Kasha, is there anything from you that you would like to ask or mention?
Yes, I think one of the things Corey, that I often hear as part of the feedback is the length of time that people have been dealing with a phobia before actively looking for a solution. So, from anecdotal feedback, we know that there is usually an event that leads to seeking help. And we also know that the duration of how long people have been avoiding or dealing with the phobia can be as big as 20 to 30 years. So, I just wanted to ask, in your practice, are you able to tell us how long your clients on average have been dealing with a phobia, and also some examples of what might have prompted them to seek help?
Yeah, and I think we've had a similar experience as what you've described, where most of our clients that are coming in to address a phobia, it's not new. It's been there for a long period of time beforehand. But one of the reasons maybe that they haven't come in for treatment is because they've been happy enough to avoid or rely on these maladaptive coping strategies up until this point. And then something changes, right, that puts them more in conflict with that phobia. Often it's workplace changes, where they may, they may be having the opportunity to travel, or their job may be moved up into a higher story in a high rise. And so they're now having to treat it to be able to move on in their life, whereas before they've kind of gotten away with it to varying degrees. So yeah, we've definitely found that same thing.
Yeah. And another question I wanted to ask you, Corey, is the differentiation between anxiety and panic. Could you tell us a little bit more about the differences between the two, and maybe similarities if there are any?
Yeah, so at the core of both of them is this fear response, is this, physiological activation. When we're looking at anxiety, which we often do use interchangeably with that kind of fear response, but it is a bit different because anxiety includes the cognitive aspect of worry or anticipation, apprehension, which is like a lower lying, level of activation when we are anticipating being in this kind of phobic situation. When we're looking at panic, though, we see that we go from seeing the threat as out there to the threat as being inward, right? We are now becoming more fearful of the threat response itself, which then spirals those symptoms. It means that if we're interpreting the threat response as a threat, we're going to get our threat response, which is what we were worried about. So we worry more, get more, worry more, get more, and this keeps going until we've sort of elicited everything our body can produce. So that is often a particularly scary experience if you haven't experienced a panic attack before, but it is also relatively short-lived because those symptoms do fatigue, on their own, if we don't intervene with them any earlier. So we tend to say that panic will reach its peak within 10 minutes and then come on down. But yeah, it's not a pleasant 10 minutes while it's there.
Yeah, no, that's awesome. Good response. So yeah, that is all the questions that I have and that everyone has asked. So yeah, thank you very much, Corrie, for joining us on this webinar. It's been awesome to chat with you and be able to get your perspective and experience on using virtual reality exposure therapy. And it's great to hear of the success that you've been having at the clinic. So thank you very much for taking the time. Is there anything else that you'd like to say before we finish off the meeting, or?
Oh no, just thank you very much for having me. And also, I remember when we first met back in 2020 when I first saw that you were starting up, and it was really exciting for us that you're making the process of virtual reality exposure therapy just that little bit easier and straightforward for clinicians as well as for clients. So thank you.
Thanks everyone for tuning into this webinar. I hope that it's been helpful. If you'd like to learn more about oVRcome, feel free to visit oVRcome.io or contact support@oVRcome.io. Thank you very much for watching. Have a great day.